At the gastroenterology clinic, there's a 63-year-old Caucasian male named Neil, who's complaining about progressive fatigue and weight loss in the last 6 months. Laboratory findings reveal positive fecal occult blood test and iron deficiency anemia. At the same time, an 18-year-old Caucasian male named Brendan came in for a colonoscopy screening. He was concerned after learning that both his grandfather and uncle were diagnosed with colon cancer in their early 30s. His doctor detected more than 100 polyps on colonoscopy. Now, both people have some form of colorectal polyps or cancer. But first, let's start with colorectal polyps, which are overgrowths of epithelial cells in the colon or rectum. They're subdivided into non-neoplastic polyps, like hamartomatous polyps, hyperplastic polyps, inflammatory pseudopolyps, mucosal and submucosal polyps, as well as neoplastic polyps, which include adenomatous and serrated polyps. Hamartomatous polyps are solitary, disorganized masses that contain normal tissue found at the site of the polyp. These polyps can occur sporadically, or in genetically inherited conditions, like in juvenile polyposis syndrome or Peutz-Jeghers syndrome, and they have mild malignant potential. Next, hyperplastic polyps are the most common polyps, and they're small and typically located in the rectosigmoid region. Usually these polyps are benign lesions, but in rare cases they can evolve into serrated polyps, which have malignant potential. Inflammatory pseudopolyps are multiple benign pseudopolyps that occur during regenerative and healing phases in chronic inflammation, and they're most commonly seen in inflammatory bowel disease. Mucosal polyps, which are clinically insignificant, are usually small, less than 5 millimeters, and they look similar to surrounding normal mucosa. On the flip side, submucosal polyps can include lipomas, leiomyomas, fibromas, and other lesions. Now let's switch focus to neoplastic polyps. Adenomatous polyps are caused by a mutation in the tumor suppressor gene called adenomatous polyposis coli, or APC for short, which is located on chromosome 5 and is responsible for the regulation of cell growth and cell adhesion. Moreover, the mutation of the APC gene is present in all familial polyposis syndromes, and most cases of sporadic colon cancer. Now let's focus on adenoma carcinoma sequence, which includes 3 steps. The first step is the mutation of one allele of the APC gene, which leads to the formation of a small polyp, also called early adenoma. The second step happens when the small polyp acquires a mutation of the proto-oncogene called KRAS, which is further followed by an increase in the size of adenoma and formation of the late adenoma. Finally, the third step requires mutation of tumor suppressor genes P53 and DCC. Now, adenomatous polyps less than 1 centimeter are less likely to acquire these mutations and undergo malignant transformation, in contrast to adenomatous polyps greater than 4 centimeters, which are more likely to progress to adenocarcinoma. Furthermore, based on histological appearance, there are 3 types of adenomatous polyps: villus, which are cauliflower-like polyps that have the highest malignant potential; tubular, which are pedunculated polyps that protrude out into the lumen of the intestine and have the lowest malignant potential; and tubulovillus, which have characteristics of both tubular and villus polyps, and they have an intermediate malignant potential. Usually, adenomatous polyps are asymptomatic, but in some cases, villus polyps can cause bleeding, secretory diarrhea, and partial intestinal obstruction. Finally, serrated polyps are often flat or sessile, and are characterized by sawtooth appearance under the microscope. They contain methylated CpG islands in their genes. DNA methylation regulates gene expression, which can cause silencing of DNA repair genes, eventually leading to more mutations and malignancy. After polyps, let's look at colorectal cancer, which is the 3rd most common cancer worldwide. Most commonly, it affects people older than 50 years old, and in 25% of the cases, there's a positive family history. Risk factors for colorectal cancer include hereditary factors, like familial adenomatous polyposis, adenomatous and serrated polyps, inflammatory bowel disease, like ulcerative colitis, lifestyle factors, like obesity, smoking, alcohol, and physical inactivity, and finally, dietary factors, which include high consumption of processed red meat and low consumption of fruits and vegetables. Individuals with acromegaly, a condition where the pituitary gland produces too much growth hormone, are at higher risk of developing colorectal cancer. And finally, increased cyclooxygenase 2 activity is linked to some forms of colon adenocarcinoma. So frequent use of inhibitors of this enzyme, like aspirin, can lower risks. For your exam, you should remember that the most common form of colorectal cancer is adenocarcinoma, and it's most commonly found in the rectosigmoid, then ascending colon, and rarely in the descending colon. Initially, adenocarcinomas can be asymptomatic, but as they grow, their location determines their manifestations. Left-sided colon tumors are usually smaller, but as they infiltrate the wall of the colon, they encircle the lumen, eventually narrowing the lumen and causing obstruction. A frequently tested concept is what the presentation of an individual with left-sided colorectal cancer is. Therefore, it's important to know that these individuals present with obstruction and altered bowel habits, like narrowing of stool, colicky pains, constipation, abdominal distension, but also hematochezia, nausea, and vomiting. On the other hand, right-sided colon cancers grow as exophytic masses, but they do not tend to cause colon obstruction, because the right-sided colon has a larger diameter than the left. Instead, right-sided tumors tend to cause chronic bleeding, eventually causing iron deficiency anemia. Moreover, keep in mind that colorectal cancer is the most common cause of iron deficiency anemia in postmenopausal women or men aged 50 or older. Other manifestations of right-sided colon cancers include progressive fatigue, malaise, and weight loss. Common complications of colorectal cancer include local and distant metastasis, but also bowel perforation and peritonitis. Non-enterococcal group D streptococci and Streptococcus bovis can also cause bacteremia and subacute endocarditis. Now, as far as screening goes, you should screen low-risk individuals at the age of 50, while individuals with a first-degree relative who has colon cancer at the age of 40, or 10 years prior to their relative's diagnosis. Screening includes visualization methods, like colonoscopy and flexible sigmoidoscopy, and laboratory findings, like fecal occult blood test, which is further subdivided into Guaiac fecal occult blood test, or FOBT, and fecal immunochemical test, or short FIT. On the other hand, individuals with hereditary polyposis syndromes or inflammatory bowel disease have different guidelines for screening, like earlier and more frequent colonoscopies. Now, diagnosis of colorectal cancer, just like screening of colorectal cancer, includes visualization methods, like with colonoscopy and flexible sigmoidoscopy, but it also includes imaging methods, like CT colonography and barium enema X-ray, which might show apple core lesions. But don't forget, diagnosis is confirmed with biopsy. As far as treatment goes, colorectal cancer can be treated with surgical resection of the colon, colectomy, and chemotherapy. What you have to know for your exam is that serum carcinoembryonic antigen levels, or CEA levels, are increased in 60 to 90% of individuals with colon cancer. But the CEA level is not specific for colon cancer only. It's also increased in pancreatic, gastric, and breast malignancies, as well as in inflammatory bowel disease, cirrhosis, and pancreatitis. Therefore, it can only be used to monitor the recurrence of colorectal cancer. Moreover, if a routine check shows that CEA levels are rising again after surgery, these individuals should undergo additional diagnostic methods, like X-ray, CT, or colonoscopy, to search for possible cancer recurrence or metastases. Finally, you should remember that aspirin and other NSAIDs can be chemopreventive in colonic adenocarcinoma, because colonic adenocarcinoma is associated with increased activity of an enzyme called cyclooxygenase 2. Alright, so now that we've covered the basics of colorectal polyps and cancer, let's look at some important genetic disorders that are associated with them. First, we have Lynch syndrome, previously known as hereditary non-polyposis colorectal cancer. It's caused by an autosomal dominant mutation in one of the 4 DNA mismatch repair genes, MLH1, MSH2, MSH6, or PMS2, with subsequent microsatellite instability. Individuals with Lynch syndrome have inherited a mutation in one allele of the gene, while mutation of the second allele occurs during adult life. Mutation of both alleles leads to colonic adenocarcinoma. For your exam, you should remember that in contrast to sporadic colonic adenocarcinoma, which is usually left-sided and happens in individuals older than 50 years of age, in Lynch syndrome, colon cancer is usually right-sided, and it happens in adults under 50 years of age. Lynch syndrome is also associated with extraintestinal malignancies, like endometrial, ovarian, stomach, and skin cancers. Next, we have familial adenomatous polyposis, or short FAP. This is a pancolonic condition involving hundreds to thousands of polyps, and it always affects the rectum. For your exam, you need to know that this is an autosomal dominant inherited condition caused by a mutation in the tumor suppressor gene on chromosome 5q22, called the APC gene. Polyps usually begin to develop during puberty, and initially they're asymptomatic, but as they grow they can present with colonic manifestations like a palpable abdominal mass, abdominal pain, diarrhea, and hematochezia. Moreover, chronic gastrointestinal bleeding from many polyps can lead to iron deficiency anemia, even in children. Familial adenomatous polyposis can be also associated with extracolonic manifestations, such as congenital hypertrophy of retinal pigment epithelium, sessile polyps in the stomach called fundic gland polyps, and duodenal adenomas. Some individuals develop attenuated familial adenomatous polyposis, or AFAP, and they end up with fewer than 100 polyps, typically in the ascending colon. Now, what you absolutely need to know for your exam is that if left untreated, polyps from FAP and AFAP can progress to colorectal cancer via two-hit hypothesis. The first step is the inherited APC mutation, while the second step is the mutation of the second allele which occurs as the polyps grow. The favored diagnostic method for diagnosing familial adenomatous polyposis is a colonoscopy, followed by genetic testing. For your tests, remember that individuals with a positive family history should start regular screening at 10 years of age. Screening includes colonoscopy once a year, and if polyps are found, treatment includes prophylactic colectomy. Now, a subtype of familial adenomatous polyposis, called Gardner syndrome, is characterized by prominent extracolonic bone and soft tissue tumors, like osteomas, fibromas, lipomas, desmoid tumors, and epidermoid cysts. Also, these individuals can have congenital hypertrophy of retinal pigment epithelium, supernumerary impacted teeth, and multiple jaw osteomas and odontomas. The next one is Turcot syndrome, which can be described as the association of familial adenomatous polyposis syndrome, or Lynch syndrome, with malignant brain tumors, like medulloblastomas or gliomas. The next one is Peutz-Jeghers syndrome, an autosomal dominant condition caused by a mutation of the tumor suppressor STK11 gene. Peutz-Jeghers syndrome is characterized by multiple hamartomatous polyps throughout the gastrointestinal tract. These can develop into colorectal, stomach, and small bowel cancer. Outside of the GI tract, there's also an increased risk of developing breast cancer. It can also present with mucocutaneous hyperpigmentation macules, which are usually located on the lips, buccal mucosa, palms, soles, or genitalia. Finally, in juvenile polyposis syndrome, there are mutations in BMPR1A and SMAD4 genes, which can be inherited in an autosomal dominant manner with incomplete penetrance, or they can be de novo mutations. Typically, juvenile polyposis syndrome affects children younger than 5 years old, and these polyps can arise in any part of the gastrointestinal tract, but the majority are found in the colon and rectum. Children with juvenile polyposis syndrome can present with hematochezia and iron deficiency anemia, but more importantly, they're at risk for developing colorectal cancer. Diagnosis is made by endoscopic studies, like endoscopy, colonoscopy, or sigmoidoscopy. And the criteria for diagnosis is more than 5 juvenile polyps in the colon or rectum, or multiple juvenile polyps throughout the gastrointestinal tract, or any number of juvenile polyps in a person with a family history of juvenile polyposis syndrome. Diagnosis is confirmed with a biopsy. Alright, as a quick recap. Colorectal polyps are overgrowths of epithelial cells in the colon or rectum, and they're subdivided into non-neoplastic polyps, like hamartomatous polyps and inflammatory pseudopolyps, and neoplastic polyps, which include adenomatous polyps and serrated polyps. The most common form of colorectal cancer is adenocarcinoma. Left-sided colon cancers cause obstruction, narrowing of the stool, colicky pains, constipation, hematochezia, nausea, and vomiting, whereas right-sided colon cancers tend to cause malaise, fatigue, weight loss, chronic bleeding, and iron deficiency anemia. Genetic disorders associated with colon cancer include Lynch syndrome, which is a cancer syndrome associated with a high risk of colorectal cancer, endometrial, gastric, and ovarian cancer. Familial adenomatous polyposis is an autosomal dominant pancolonic condition involving hundreds to thousands of polyps, caused by a mutation of the APC gene. Gardner syndrome is a subtype of familial adenomatous polyposis characterized by prominent extracolonic bone and soft tissue tumors, while Turcot syndrome can be described as the association of Lynch syndrome with malignant brain tumors. Peutz-Jeghers syndrome is an autosomal dominant condition caused by a mutation of the STK11 gene, and it's characterized by multiple hamartomatous polyps throughout the gastrointestinal tract and mucocutaneous hyperpigmentation macules. Finally, in juvenile polyposis syndrome, there are mutations in BMPR1A and SMAD4 genes, which can be inherited in an autosomal dominant manner with incomplete penetrance, or they can be de novo mutations. Typically, juvenile polyposis syndrome affects children younger than 5 years old, and these polyps can arise in any part of the gastrointestinal tract, but the majority of them are found in the colon and rectum. Children with juvenile polyposis syndrome can present with hematochezia and iron deficiency anemia, but more importantly, they're at risk for developing colorectal cancer. Now let's go back to our case. In 63-year-old Neil, you should suspect colon cancer, because colorectal cancer is the most common cause of iron deficiency anemia in postmenopausal women and men 50 years or older. Also, positive fecal occult blood tests and nonspecific symptoms like malaise, fatigue, and weight loss should make you think of right-sided colon cancer, and order colonoscopy and biopsy to confirm the diagnosis. Based on the severity and involvement of the colon, Neil can be treated with surgical resection of the colon, or even total removal, colectomy. Next, Brendan has a family history of early colorectal cancer, and the presence of hundreds of polyps were detected in his colonoscopy, so he was diagnosed with familial adenomatous polyposis. He requires prophylactic colectomy because individuals with familial adenomatous polyposis are at high risk of developing colorectal cancer later in life.